Okay, so look, I wasn't quite sure what Josh wanted me to talk about here, but just to stop him from stalking me at the Queen Elizabeth, I thought I'd better say something. So, look, it's a lot more light-hearted than Mr. Anthony's talk. And look, you really should recognise that Mr. Anthony, he's the Censor-in-Chief of the college. So it's like a talk from the Attorney-General of the Commonwealth Government of Australia. So we're very privileged to have had that little, snapshot. So thanks, Adrian. We're all on a bit of a high today because several of the boys passed the fellowship. So we're all a bit pumped and happy. So that's a good thing. So I'm going to talk about my journey through medical education really, and how I got dragged into research, and show that anyone can do it if I can do it. So I've got no apologies for overuse of pop culture. For those of you who have suffered through some of my addresses at the end of declaration ceremonies, I always manage to put in a Homer Simpson or Family Guy thing. So take note, see how many you can pick. Okay, so look, I started at the dark side. I did my undergraduate degree at Flinders. The year was 1982, a long time ago. Admission at that stage was via matric scores, and we had a very flimsy interview system, I guess you'd say. It was a 6-year degree back then, so it was the undergraduate degree. It was very much systems learning though. So the first year was, biology and genetics and all that sort of thing. But when we got into second year, we split into, cardiology and then, renal and sort of not completely dissimilar to what we're doing here now. There was very early clinical immersion at Flinders. So in first year, we went to GPs, and we didn't know what the hell we were doing or looking at, but we started with GPs in first year. And then from second year onwards, we were always on the wards to some degree. We had a research project for the entire year 4, where we, I think it was a day a week was dedicated to it. So by the end of the year 4, everybody had a project to present, and often a paper would come out of it. So that was quite useful. Our final exams were in year 5. So we had, surgery, psych, medicine, O&G, paediatrics. And so when we came into year 6, it was just clinical student internships, and we had the wonderful facility at Flinders of repat. So that was like, we were like interns for all intents and purposes, and it was just magnificent. So it was a pretty different era back in 1982. Anyone? Who is it? Flock of Seagulls, Iran. So this is what we were listening to. Hawthorne were dominant in the 80s. Now, just as a little bit of a by the way, so we've got Robert Domenico, Dermot Brereton with that stunning mullet, and John Platten just out of shot there. Now, what's interesting to note is John Platten can't remember that game because he was concussed heavily. And, they let him go back and play, but he didn't know where he was. Dermot Brereton got cleaned up at the centre bounce by Mark Yates from Geelong. He had a lacerated kidney and 2 fractured ribs, but kicked 3 goals and turned the match. Dippy Domenico nearly died. He had fractured ribs and had a pneumothorax. So he actually had surgical emphysema at the end of the match, and if they hadn't have put a tube in very rapidly, he probably would have died. So it was a different time, as it was with medical education. It was a different time, and thank the Lord we've moved on from there. So it was widely regarded as the best grand final ever. Hawthorne won by 6 points against Geelong. And of course, the best film ever made, Ferris Bueller's Day Off, 1986, absolute classic. So, in the 1980s, at Flinders at least, there was a little bit more of an effort made at small group learning. But, there was no access to lecture notes. So, your recollection of what happened in the lectures was completely dependent on who had the best vision in the class to take down notes quickly. All right, and we'd often, we knew who had the best vision, we knew who had the best notes, and we'd sort of, put the hard word, give us a copy of your notes. But that's the way it was. Nothing was given to us beforehand. There were prescribed textbooks, so we all had a copy of Harrison's or Sabiston's or whatever. And there was no documented curriculum. We wouldn't have known where to look for it. If it must have existed somewhere, but who knows? And there was no internet. So we're talking ancient history. Now, what's this? Well, this is a group of Flinders students turning over the librarian's car because there was only one copy of a text that everyone needed. I'm kidding. That was actually a riot at Glenelg, believe it or not, in 1984 after a Proclamation Day concert. So pretty wild, the 80s. So we move forward to the 90s. I've made it through Flinders and started working. And even back in the 90s, there was a very strong expectation that residents and registrars would take separate and dedicated teaching sessions in the form of ward-based tutorials. So you'd often see, you know, in the afternoons, registrars taking a gaggle of students with them. I mean, it was just accepted. I mean, it was almost like written into your contract. And somewhere along the line, that's kind of disappeared, which is very sad. At the University of Adelaide, a lot more effort was being put into curriculum design. There was this wonderful unit called the Medical Learning and Teaching Unit, which really controlled everything. But we had a curriculum, and it was interwoven with the various years, and that was certainly a good thing. But perhaps the most significant change towards the end of the decade was the introduction of these things called SCAPs, so Specialised Community Ambulatory Placements. And this is kind of where I guess I started to dip my toe in with research, because Professor Maddern, who's mentored many of us in this room, said, well, we want to start putting students from the University of Adelaide out into the country, which now, of course, we laugh at and think, oh, well, hasn't that always happened? But no, I mean, up to that point in time in 1996, there was virtually no expectation that students had to go to the country. And in fact, I think we only had, the only sort of community medicine need was 2 weeks out of the entire 6 years. So it was quite revolutionary. And so he said, right, Bruening, you organise it. So I organised with Mount Gambier and initially Pirrie, Port Augusta, Whyalla and Port Lincoln. We're going to have 6 years out there for 6 weeks at a time. So this was very revolutionary. And I must say there was some resistance with the older guard within the university, thinking that, well, what could they possibly learn out in the country? And just to put it in a little bit of a context, Professor Maddern had supplied surgical services to Port Augusta for several years leading up to about 1997. So he was well aware of the wonderful teaching content that occurs out in the country. And he sort of said, well, it's a pity that all goes to waste. And maybe we should start doing it. So in 1997, we all held our breath, and the first lot of students went out, and everybody got there safely and on time. And not surprisingly, everybody had a really good time. So 1990s, what were we listening to? Anyone? Right, said Fred. I'm Too Sexy. All right. 1993, big hit. 90s dominated by North Melbourne. Somewhat of an ironic photo, given that Wayne Carey there is got his arms wrapped around Anthony Stevens, and we know how that all ended a bit later on in the early 2000s. And Billy Madison, still doing big business on 7 Mate. Most Saturday nights, in fact, it's on there, so do yourself a favour. So for the 1990s, I started thinking more about research because I'd established, all these placements. All of a sudden, we've got 40 University of Adelaide students going out to these areas. And, you'd be surprised, but with the whole rural situation, and we all thought there was great teaching out there, that's true, but nobody had ever written about it. So, especially with surgery. So, everybody said, oh, what are you writing about that for? We know that there's great teaching out there. We know that, well, where is it documented? So basically I set about, polling the students and surveying the students and the surgeons and making logbooks and seeing what they actually did in relation to what the equivalent was in town, and they were seeing like 5 times more things than people were seeing in the metropolitan area. So all of a sudden there was all this information that nobody had really written about because everyone assumed, oh, well, that's obvious. But this is the point of research, is that often people make these assumptions, especially with the so-called, slightly, I'll call them softer sort of topics. It's not a lab, it's not looking down a microscope, it's not, quantifying things, but it's really important. And if you can actually write about that, then that puts you ahead with a lot of things. So at the end of the decade, going into the 2000s, I'd completed a Master's in Surgical Undergraduate Education. And, articles started appearing. So we actually proved, because this was also important to change the attitude at the University of Adelaide, that rural was a good thing. We had to prove that the teaching was as effective as the metropolitan area, and we did that. And slowly, the tide turned in terms of rural teaching, which was a good thing. So as the 2000s rolled on, and I got my fellowship and I started becoming involved in the curriculum committee, we moved our final exams back into Year 5. A bit Flinders-esque, really. I mean, that was a big thing for the Adelaide. So Year 6 became a student internship year. So we kind of mirrored a little bit what Flinders had done for quite some time. And interestingly, the success of the 6th year rural SCAPs led to the commencement of 4th year SHU rotations, so the 9-week rotations. And given the success of that, it was the launch of the Adelaide Rural Clinical School, so we could prove that we could do that. So rural school has now been present for 20 years, and it's really great that that early initiative by Professor Maddern had morphed into this thing now called the Adelaide Rural School. And along the way, we did sort of more research about, and we were asked to contribute to the surgical clinics of North America with a chapter about, the Australian experience, because, the experience in South Australia is very different to the experience in the eastern states, where, they've got the Bendigos and the Ballarats and the Wangaratta's, where there's, 80,000 people, 70,000 people. So they can have, 3, 4 surgeons there resident, whereas, we've got Whyalla, Port Augusta, they're smaller. I mean, you try being a surgeon there for any length of time by yourself, it's a killer. So we have had this rotating system for many years where one of us would go up for a week at a time, and that seemed to work very well. So we continued that interest, and student attitudes towards surgical teaching in provincial hospitals. It was positive. So the 2000s, we've got Gaga. Everybody knows Gaga. She started quite early, 2004, I think, poker face. Brisbane Lions dominated the football field, all right. And, what can I say? Step Brothers, classic. All right, but the 2000s have also brought us this, empty lecture theatres, which is perhaps one of the things that we scratch our heads about. What's happened? Are lectures a thing of the past? How should we deliver content? We've got a continuing and increasing reliance on IT, and it's really hard to determine what is actually relevant. So for many years, we've been basing everything we do in the medical school on Halstead. So Halstead was a chap, he was a surgeon. He sort of was instrumental in founding Johns Hopkins in the US, and sort of the modern day model of the medical schools really after him. So the apprenticeship model, it's really stood the test of time. So see one, do one, teach one. We've all heard that. Kind of comes from Halstead, sort of well over 100 years ago. Now, while we've got the wonderful SimLab, simulated training and learning, and who knows what's going to happen with AI, it's really only an adjunct to the learning that we get at the patient's bedside. So how can we maintain this? And the challenges are trying to provide consistency of experience across a wide variety of learning centres. That's really hard, because we know that at the Royal Adelaide it's different to the Queen Elizabeth, it's different to Modbury, it's different to Port Augusta. We can't put everybody through the same thing all the time, there's only so much that we can do. So providing consistency is a really difficult challenge. Refreshing the curriculum and, importantly, trying to determine what is relevant and what isn't is a challenge that we fight with. And also the increasing influence of outside bodies, especially the Australian Medical Council. Now, for those of you who don't realise, the Australian Medical Council are like the overlords of everything medical in Australia. And they come around, at great expense, every few years and go, you're doing a good job or you're not doing a good job. And then they give us conditions if we're not doing a good job and say, right, by the time we come around next time, 2 weeks' time, you must have changed this, this and this. So they're called conditions. And there's about 8 sort of different categories that we have to sort of tick all the boxes with, and they'll give us conditions. And then we have to improve to the satisfaction of the AMC, the next time they come round. Now, can they close us down? Technically they could. They haven't to any other medical schools so far, but they certainly keep us on our toes. And it's not, I don't know what Mr. Anthony thinks, but it's not impossible to think that the AMC is becoming more and more descriptive about what we should be doing and all the graduate outcomes. It's not impossible to think that maybe in 10 years' time they'll be telling us what the curriculum has to be, which would be kind of a little bit sad and a little bit scary, because then the government could say, all right, well, we'll do that in the first 3 years and, the medical schools can do the last 3 years, but I digress. The challenge is also in terms of medical education, from 4th year onwards, people are in the hospitals. We have to have a good relationship with SA Health. If we upset them, then it gets really difficult. And we've got a huge reliance. We couldn't do the job that we do without relying upon our clinical title holders. So, lectures. Is it a bit like Mad Max? At the end of Mad Max 2, kind of all washed up and nowhere to go. I think the lectures are perhaps seen their glory days and are probably heading into the sunset. But you have to realise that for many of the clinical educators or clinical title holders, so people who aren't employed by the university but do the teaching for the love of it, for many of them, probably my generation, maybe a little bit younger, but around this era, they really love giving lectures. It's the face-to-face that they love. They hang out all year to give their 1 or 2 lectures. So for them to say, for us to say, look, lectures are a thing of the past, write up some notes, and then we'll do small group discussion. It's a big thing, and we have to keep the clinical title holders happy, or else, we've got nowhere to go. So are our options predetermined learning material, which I think we're probably doing to a greater degree now, especially with the new BMST course. A lot of case studies and casework, and then group discussions. But even then, how many groups do you have? How big are they? Is Group A going to get the same experience as Group B when discussing cases? So there's a lot of things to work through. But at the end of the day, it requires a significant commitment from individuals who are really not employed by the medical school. So it's really hard. So, lectures, that's it, man. And of course, you'll all recognise that's Corporal Hudson from Aliens when faced with the onslaught. It's game over for lectures, I think. So what's this got to do with the research? And unfortunately, one slide of the Callan executive slipped in there, but what's this actually got to do with research? Well, without commencing the research that I did over 20 years ago, I certainly wouldn't be here today. And by researching a topic which didn't fit the usual mould, so it wasn't, lab, it wasn't white coat stuff, it wasn't trying to cure cancer, you soon become a relative expert in the field. So to this day, there aren't a lot of articles, apart from Bruening and Maddern, talking about rural surgery. And so, by taking something which is, not fashionable, and admittedly having a bit of an interest in it, you can become an expert. And this is, for me, this is kind of continued with research and supervising people doing PhDs in topics outside the norm. So at the Queen Elizabeth, we've had a lot of work done on surgical coaching that some of you might be aware of. So that's the concept that if I finish my fellowship, technically speaking, no one assesses my work after that point in time. I mean, I know there's clinical audit and all that sort of thing, but really I can keep doing the same thing for the next 40 years. So the whole concept of surgical coaching where, a peer will say, well, you could have done this a bit better, or why don't you try doing this, or it's a new concept. It requires, a bit of work and input, but, that may well be a thing of the future. The other thing that we're doing at the Queen Elizabeth, which is once again outside the norm, is trying to change the whole ward round. I don't know about you, but the ward round's chaos. You got 10 people on a consultant ward round, 5 people are having a separate conversation. The nurse comes in to ask about the last patient you saw. Patient's just in the bed thinking, what the hell's going on? So it's chaos, and when you think that that's the most important part of the day, where decisions get made for the whole day, discharge, operation, investigations, whatever, can we do this better? So we're currently doing a study on the sterile cockpit, which is from the aviation industry. We've just got a couple of people doing the main ward round, nobody disturbs them, and we just see how much more effective that could possibly be. So once again, it's not a topic that, is, the sexy, hardcore sort of thing, but nonetheless, it's important. And, the college, what Mr. Anthony's pointed out about the whole, all the various things that we have to think about now. I mean, 20 years ago, people would have laughed at you if you said, oh, non-operative surgical skills are important. And now it's really important. They have exactly the same impetus and importance as actual technical ability. So everything changes. So, tips. Don't rush it. There's plenty of time. You don't need to be a consultant with a PhD by the time you're 30. All right? Enjoy yourselves a little bit. Do something that you're interested in. I was interested in rural stuff and obviously interested in surgery, and interested in medical education, so it all worked out very well. Do the appropriate preparatory work. I mean, before you commit yourself to jumping in and doing a master's or a PhD, write a few papers, see if this is what you like to do. Importantly, probably the most crucial thing is have a good team to work with. And as Mr. Anthony said, at the bottom line is that you need to be a good clinician. So don't take your eye off the ball. It's all well and good to sort of think about all these other things, but you need to know what Mr. Smith's potassium is after his Whipple's operation. You need to know how much is in the drain. All right, so you need to be a good clinician. So thank you for your time, and I'll just leave you with the words of he who must be obeyed, Ferris Bueller. Life moves pretty fast. If you don't stop and look around once in a while, you could miss it. So enjoy yourselves, and there's a role in research for everyone. So thank you. Questions? Yeah.
AMC.
Yeah.
How objective are the criteria upon which they judge medicals?
Yeah, so the AMC, it's like, I won't say the circus rolls into town, but there's a lot of them that come into town. And then they, I mean, obviously they've got a hard job to do. They have to maintain the standards. And they do the accreditation for all the hospitals and everything else. So they're busy people. And they will meet with, the medical school executive, they'll meet with the clinical title holders, they'll meet with the medical students, they meet with a lot of people. So they're hearing it from all angles. And I guess, all of their graduate outcomes, they've added another 2 graduate outcomes in the last 2 months, which will come into play next year. I guess it all comes from a good background. But, so there'll be more of an emphasis on medicine and the environment, for instance, which you could argue about. I don't know, but anyway. And, computer literacy, which is fine, cultural advocacy, and more of a push on Indigenous health. But I think it probably all comes from a fairly strong background. It's just that you have to do it. And, by the time we finish one report, they're coming again. So it's just this constant thing. So, you know, I don't want people to think that we sort of just, you know, make the curriculum up on the fly and, you know, it's got no structure to it. We have to fit it in within the various graduate outcomes. And then we've got to look at our domains, so the 4 domains. So it's a big puzzle, and it doesn't get any easier with the AMC. Having said that, they're generally supportive, and you know, if we're, you know, under-resourced, they'll bring that up, and that gives us a little bit of leverage sometimes to get more resources. But no, they're all powerful, and you know, I think their heart's in the right place, but it can get hard. Yeah, Josh.
Is there, this is for both of you really, but is there correspondence between medical schools and colleges about like the competencies for the getting to specific medical or surgical training programs? Is there alignment with like medical school curricula? Is that moderated by the AMC?
No, there isn't. Look, in the perfect world, people talk about the continuum of education. And so, you know, you finish medical school, training, lifelong learning. And certainly I think with the, you know, the 2-year internship, there'll be more alignment, because a lot of people that will be, you know, looking after the interns are also involved with medical school, and it kind of makes a little bit of sense. But to try and add that onto the college, that's a whole another level of, you know, bureaucracy and difficulty that we could probably do without. I mean, in the ideal world, yes, so that we could tick off all the various boxes. I mean, you know, if I was king, I would, you know, 6th year medicine, you'd do all your competencies and all your mandatory training that you do as an intern. You know, you'd do that already, and for all intents and purposes, in 6th year you'd be like an unpaid, you'd be an employee that's not getting any money for the various health networks, so that it'd be a bit of a more seamless transition.
I guess the other thing to understand is that the AMC actually accredits the whole continuum. They accredit medical schools, they accredit internships, they accredit colleges. And so when I hear, oh, this is these are the new graduate outcomes that have been articulated for medical school, I then have a look, and then sure enough, there they are for interns, and there they are for college of surgeons. So they've been trying to keep them in that sort of same mould, if you like, and try to keep it seamless. But of course, medical schools don't control what, AMC doesn't control exactly what the medical schools do, or the the hospitals that employ interns, or the colleges. So that's why there's a bit of an apparent disjoint. But you know, I think overall, you know, the standards are applied across those 3 key groups, and of course now they're also involved in continuing professional education for people like us, surgeons, you know, and any specialists. So we have to keep up with our CPD, and the AMC has actually had some say into what goes into that. So yeah, I think there is that overall framework, but you know, it can seem a little bit disjointed.
And sorry, on a similar note, like, does Australia and New Zealand function on its own, or is there, at a medical school and postgraduate level, is there correspondence with other countries or other colleges? Like, is that moderated, or is it?
Well, I mean, Australia and New Zealand, I mean, the Medical Deans Society of Australia and New Zealand, so there's regular meetings there, so I think we're pretty much on the same page. But in terms of any other, you know, dialogue with other countries, no.
Yeah, not systematically. The AMC accredit all universities across the 2 countries, so they do it on behalf of the Medical Council of New Zealand. I mean, there are groups who like to reach out to Adelaide Uni. You know, Martin and I had an email the other week from one of our colleagues saying, oh, there's this university overseas, wants to maybe have some links, and those links do occur. But there's nothing systematic about it. The other thing to bear in mind is that, you know, we have a very high quality healthcare system, and to go with that, we have a very high quality health education system. So a lot of other countries are looking to Australia to have those partnerships and to tap into that. You know, so there's only certain things that we can do, and you know, we can't just give away our intellectual property. But you know, there's the opportunity for having electives and that sort of thing.
Yeah. Yeah.
I think your point about lectures going away is a very interesting, kind of sad one. I enjoy lectures as well. People do, like we're all here. Do you think there's a way to keep them going?
I don't know. I mean, we get so much feedback from students saying, oh, you know, it's not engaging, or it's not exciting enough, or they're too early, they're too late, they're too long. You know, I could write a list. But look, to a certain degree, it is, I think the dissemination of information via a lecture, it's pretty outdated, I think. You know, the internet's just gone bang. It's changed everything. You know, from us, you know, having fist fights over, you know, articles in the library at Flinders to, you know, just going bang, 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 ta-da, there it is. Now, I think that, you know, everybody that gets into medicine's intelligent. They can, you know, look at the information on the internet or whatever, you know, lectures we might give them as a preparatory thing. I think the key really is though case, you know, talking about cases, case presentations, you know, putting it in a scenario. And then of course, it's having that person with experience to sort of discuss it. And, you know, as I said before, how many do you need? Can I discuss a case of appendicitis with 120 students? I mean, maybe. I mean, it's probably not impossible, but I think we have to get away from didactic, you know, this is blah, 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 because it's done so much better in other forums. And, you know, look, don't get me, I love lectures. I think they're a great thing, but I think as a dissemination tool for, you know, knowledge, I think it's probably had its day like, you know, dear old Mad Max.
Your 2 points. The first one being the point about, I guess, I think it was more so back in the 90s and 2000s, where there was like an expectation for such culture of registrars going off with a group of students, and that's kind of faded into antiquity almost.
Yep.
I personally feel like that's not for a lack of wanting to. I feel like maybe the time pressures of the current health system preclude that.
Yeah, look, it's ironic, isn't it? Because, you know, Mr. Anthony could probably back me up on this, but we've never had more residents, interns, registers. And it's crazy because, you know, we all used to do the stupid 24-hour shifts and all, you know, walk around like zombies the next day. But yeah, somewhere in the 90s it just disappeared. And, you know, the quite rightly, you know, the Health Commission think about outcomes, get it through economy. You know, while they say they're interested in teaching and research and all the rest of it, if you put them under the spotlight, they'd probably crack and say we're not really interested. So even though there's money that's meant to be attributed to teaching, I think it all gets caught up in the general pool. And I guess the other thing is, you know, we can all remember, you know, when, you know, Mr. Such and Mr. Such and Such used to do the ward rounds, you know, just a teaching ward round. And, you know, it'd be the registrar's job to pick out interesting cases for the week. And, you know, the autopsy teaching sessions in pathology at Queen Elizabeth were fantastic. And it's all gone, predominantly because of time pressure. But, and I think patients' attitudes have changed too. So I don't think that the huge consultant ward round's got any teaching potential in it at all. I think it's all about business, which is fine. I think you can have a separate ward round, that's fine. But, you know, it's really not structured these days for teaching, I think, as a thing.
The other point I had is the reliance on clinical title holders. I thought that was interesting because I myself once, so I get those emails about who's wanting to like help Markovsky, that sort of thing. It's always, I every time an opportunity has come up, I've wanted to say yes, but work has precluded.
Yep.
And I find the irony of that quite interesting.
Yep.
Do you know if there's any way to, I guess, ameliorate that gap, or is something the school might benefit from, with discussions about how to better engage?
Well, actually, we're doing that. We've actually started a clinical title holders working group, and that's certainly being flagged as a major potential risk for the medical school if we don't, up our game with, recognising the great efforts of all these people. And, it's, you may or may not be aware, but there will be clinical deans at Callan, Nallan and Women's and Children's. So their job will be to, engage the clinical title holders and basically make their hospitals as tempting to students as they possibly can. So with the clinical deans, we're hoping that there might be some leverage with, SA Health and, this is what we need. So I think that's a fairly exciting development, and, hopefully that'll happen pretty soon. But it's hard. It's all this relationship with SA Health, which is seemingly sometimes a lot one way.
Yeah, no, it's difficult. Because I can remember going through CBL, and I can't wait to do this when I'm lead a small group discussion and sort of thing. But even just today, I tried to peel off to do a little shoot for my fourth years, and I had the nuns banging on the office door because I needed the discharge summary because someone had been accepted for Hampstead rehab. 45 minutes is not going to get away.
Yeah, well, it does. Yeah. So yeah, I mean, a lot's changed. So pressure to get people out. Patients don't really want to. I think it's less these days to have patients say, "Yeah, come and examine me." And the nurses are a lot more protective, I think. I think in some circumstances, rightly so. Having people, prod the patient and all the rest of it. So a lot's changed. A lot's changed. But it's still good. All right, good. Yeah, Karl.
With regards to lectures, has there been any study or look at the outcomes of students or pre-clinical students during COVID?
Yeah, because I didn't mention COVID in the talk, but of course COVID changed a lot of things. So we sort of were dragged into the 21st century and, had to put everything online and tutorials, and, people turned out all right in the end. I mean, you wouldn't want to, keep the COVID situation going forever because it was that clinical contact that got lost. And we're perhaps seeing it in some of the medical students now who missed out on some of those in the preclinical space, at least, in talking to patients and getting that experience, who are perhaps not quite as up to speed as some of their forebears were, I guess. But there's a lot of information about COVID and teaching and remote teaching. So yes, it's been done. Yeah. I mean, students, they say we love the pre-recorded lectures and all that, but then we want face-to-face as well, but then people don't turn up. So, it's really hard. Well, look, it's fair to say that as we move into the BMD for the clinical years 4, 5 and 6, we've got an opportunity to rejig things a bit. And I think that's probably on the cards with lectures, and whether we call them lectures or split them up into seminars or workshops or small group learning, I think there'll be a big change in that sort of thing. And all the medical students are going to get microchipped so we know where they are. I think I'm joking. All right. No other questions? Great. Okay, good.